First thing I want to do is thank the Memphis Pediatric Society, their leadership and their team for really inviting us to do this collaboration that involves Memphis Medical Society and Bluff City Medical Society. The Pediatric Society leadership is Dr. Andrew Nern, who's with us tonight, Dr. Jason Yon, Dr. Emily Doish, and Dr. Jennifer Lum. We really appreciate the partnership with you guys. Also joining us tonight is Dr. LaTanya Washington. She is the president of the Bluff City Medical Society, always a good partner of ours, and glad to have her with us tonight. And then want to thank the Memphis Medical Society leadership and staff, particularly Cara, who's trying to be deceptive by calling herself Memphis Medical Society on the Zoom, but Cara is really the glue that keeps all this together and keeps things moving for a lot of these organizations. So thank you, Cara. And then I'm not sure if we have any representatives from the Nashville Academy of Medicine, but they were nice enough to promote this event. And I would imagine we have some members who are watching or will be watching, which brings me to the next point that someone else may mention this later, but I do know that we're recording this tonight. Is that correct, Cara? Yep. So we're recording this for posterity and all of that. So now I'm going to hand the meeting over to Dr. Nern. We've got some announcements and some guests to share. Dr. Nern.
Thank you, Clint. I appreciate it. Welcome, everybody. We are in store, I think, for a great talk from Dr. Brandt. I'm curious to see what all she's got going on, because I know we've got a lot of important stuff regarding the Gardasil and HPV and cancer prevention. Anyway, before we get started, I'd like to invite Casey Maiden, and I might have mispronounced the name, from Christian Brothers University, and so we can hear about the Preceptor.
Thank you so much, Dr. Nern. Yes, okay, all right. So thank you all so much for allowing me to speak today. I wanted to share a bit of information about the physician assistant program at Christian Brothers University. I'm going to start by going through a little bit about our program, a little bit about PAs, and then briefly talk about our opportunities for precepting. So my name is Casey Maiden. You did a great job, Dr. Nern. That's exactly the pronunciation. Most people don't get it correct at the first time, so thank you so much. I'm the director of clinical education, which means I oversee the clinical phase of the students' orientation, of the students' education. So what are PAs? You know, most people are familiar with PAs, but I wanted to give a brief overview. We are licensed to practice medicine through employment of a supervising physician. You know, our medical model is collaborative, team-based approach to healthcare, where we collaborate with a supervising physician and practice in congruence with a physician-led practice. PAs work in a variety of medical settings, from family medicine and primary care to all medical subspecialties, and PAs are present really in any type of medical setting: inpatient, outpatient, operating room, etc. Our program specifically, our mission is that we are committed to training PAs to better serve the healthcare community, healthcare needs of the community, of the region, state, and nation. And we also have an emphasis on serving the rural and medically underserved communities in Metro Memphis and in the Mid-South. So we do actually have a grant which allows our students to have opportunities in some underserved communities where they wouldn't typically get exposure. So we're very fortunate to be able to provide those opportunities for our students. Our program is a 29-month program. The PA programs, when they were initially started, are based on the medical model. So you'll see that a lot of PA programs are structured very similarly to medical school, just on a smaller scale. Our program is 15 months didactic classroom experience and then 14 months clinical rotations. So essentially 15 months of combined M1, M2, and then 14 months combined M3, M4. The clinical phase, which is my specialty, consists of 9 5-week, 5-credit rotations that run summer to summer. And that's after they've already completed their classroom training. The rotations that we require as a program: family medicine, internal medicine, behavioral medicine, surgery, could be any surgical subspecialty as long as students get exposure to pre, intra, and post-operative care. emergency medicine, pediatrics, prenatal and gynecologic care. We do require a rotation in orthopedics, which is a bit unique for our program, and all students get an opportunity to do an elective. So what do we require for somebody to be a preceptor? You must be a board certified physician in the area of study, meaning if you're an internist, in order for it to count for an internal medicine rotation, you do still have to be board certified in IM. The students have to spend a minimum of 32 hours on site. Most are typically there a lot more because, you know, they're working whatever schedule the preceptor has them working, which is usually their schedule. So it's usually a lot more than 32 hours for a total of 5 weeks. One thing that is a bit unique to our program is that several months ago, we started offering a stipend for preceptors because we recognize that our preceptors do a lot for our program, and we wanted to compensate them for that. So we do offer a $500 per student stipend. And the responsibilities are that the student should be actively engaged in patient care, seeing patients, getting histories, doing physicals, any procedures or anything like that, that as a preceptor, you would be comfortable with them doing. So why would someone want to precept? It's an opportunity, obviously, to give back to the community, to educate the future healthcare professionals. It's an excellent hiring opportunity. If you had a possibility of wanting to hire a PA at some point in the future, there's really no better job interview than you have with a 5-week rotation where you really get to know them. Obviously, a stipend of $500 per student, while we recognize it is extra work, it's nice to have that little bit of extra cash coming in. And really, it's educating future providers in your area in the way that you want them to learn. And so, you know, I think it's really important that, you know, even if you don't have an interest in working with PAs, even if you don't have an interest in hiring PAs, it's important that, say, you know, if you're a pediatrician, that you're teaching future PAs who might work in the emergency department the basics of pediatrics so that your patients are treated the way that you would want them to be treated when they're seen in that emergency department. So, you know, it really is beneficial to the community as a whole. So our program, we just graduated our first class, and the class of 2020 had a 95% pass rate on our certifying exam, which was excellent for first-time takers. And then the students who failed will be retaking the exam. So we're hoping for 100% pass rate at the retake. So if anybody has any questions about our program, feel free to ask me now. If not, I have my contact information up there. If you're interested in precepting, please reach out and we can have a further discussion about that. Any questions? Okay, if not, thank you all so much. I really appreciate it.
I appreciate it.
Okay, thank you.
And let me just give you this personal testimonial real quick with the CBU program. I'm at Christ Community Health Services, and we have PA students come through fairly often, and we think very highly of your folks, of your students. They always are delightful, and they do a great job in the clinic. So if y'all are at all interested, I would definitely pursue that.
Thank you. I really appreciate that testimonial. Great.
Okay. All right. Next, I'd like to introduce Ms. Juanette Jones from Porter Leith. She directs the Books from Birth program, which also at Christ Community we benefit from greatly. So I would love for her to speak up and let us know what's on her mind.
Good evening, everyone. Good evening, Dr. Nerd. And thank you all for the opportunity to share with you just a moment. Dr. Jan has helped to connect us. Just to remind you all about our program, we're going to come back to another meeting, so we don't want to take too much of your time because you have a great presentation ahead of you. So as you all know, early literacy and language acquisition and early childhood education and development are connected to health and health well-being, and are among the list of social determinants of health. And so we are here, hopefully, to remind you and maybe even introduce some of you, if you're not familiar with the local affiliate of the Dolly Parton Imagination Library. It's known as the Books from Birth program. As Dr. Nerd has mentioned, Christ Community works with us, and as well as ULPS, as our first UOPS had our first reach out and read location, and Dr. Nern has that second. But we have the reach out and read program, and we're happy to talk about that at a future date as well. But we want to share with you that the program exists here in Memphis. It serves as the largest affiliate in the world, and that you guys are on the front line in helping us to enroll more families into this program. The program is no cost to our families that live here in Shelby County from birth to age 5. I'll put all the details in the comments for the interest of time so that you can hear Dr. Brandt's presentation. But the program is available to your families from birth to age 5. And I'll stop there in case Dr. Nern or Dr. Jan has anything that they'd like to add. And we look forward to presenting to you in your future meetings.
Well, I really appreciate all that you do for us and for Christ Community and for the kids of the Mid-South. You'll make such a great impact, and I really appreciate what you do.
Thanks, Dr. Nern.
Okay, and thanks for joining us. All right, and now I'd like to introduce to you all Dr. Heather Brandt, who is at St. Jude Children's Research Hospital. She's a full member, director of the HPV cancer prevention program, and she has her fingers in a lot of pies, I think, over there at St. Jude. And Dr. Brandt, definitely glad to have you join us tonight. And I appreciate your time, and I will let you take it from here.
Sure. Thank you so much, Dr. Nern, and thank you everyone for inviting us to join you. But anyway, I'm just really glad that Carol Miner, who's joined us tonight, wave Carol so that they can see which one you are, of course. So Carol's been working with Cara and talked to some of you. I've also had the chance to talk with some of you, and we have 2 of our other team members, Andrea Stubbs and Julia Neely, joining us tonight as well. And I'm very excited to have the chance to present to you and give you a little bit of the latest information on HPV vaccination for cancer prevention, as well as talk a little bit about the effects of the pandemic, which have been extreme in the case of vaccinations, particularly for adolescents, and then also have a chance to share with you some resources that are available. All right, I think we have this going okay now. So I just ran through some of the things I'm going to cover today. So this new program at St. Jude is really focused on HPV vaccination as cancer prevention. It's important because part of this story of HPV vaccination as cancer prevention has its origins many, many, many years ago. We know that there's been a lot of advancement in the science of understanding the etiological linkages between HPV and various disease outcomes that go back to mummified remains in ancient Egypt. Fast forward into observational epidemiology, where investigators in Italy noted that nuns rarely developed cervical cancer, yet women who were working in brothels were developing cervical cancer at very high rates. And then all the way into the 1980s, when a German scientist, Dr. Harald Zerhausen, finally made the connection between HPV and cervical cancer as a first step. So there's been a long history in understanding the connection between HPV and these various types of cancer. So currently there are 6 types of cancer that are known to be linked back to HPV with varying percentages or proportions of attribution. Almost all cases of cervical cancer, particularly squamous cell cervical cancers, but also adenocarcinomas of the cervix, are linked back to HPV. And then there's some varying attributable proportions for these other types of cancers, which I'll share with you in just a moment. We also know that more than 500,000 cases of genital warts are diagnosed every year in the United States, and HPV types 6 and 11 are the causes of those genital warts. HPV 6 and 11 was included in the original Gardasil and also in Gardasil 9, and we've started to see some decline, but not as much as we would like here in the United States. Other countries have started to see even greater declines in genital warts cases as a result of high levels of uptake. And then lastly, recurrent respiratory papillomatosis. This affects about 1,000 or so babies each year for the pediatric or congenital onset of RRP. And we know there are still juveniles and adults who are diagnosed because their cases perhaps weren't as severe at the time of birth, but then they develop symptoms and their teens or as adults. And there are, again, about 1,000 cases of those, 500,000 cases of genital warts, 36,000 cases of these cancers, plus another 200,000 precancers of the cervix. Now we're closing in on close to 800,000 people each year in the United States who are affected by HPV. And so these attribution proportions are shown here. You can see for cervical, technically 91%, and then different types of cancer, anal cancer also 91%, and then vaginal, vulvar, penile. And the growing cancer right now is actually oropharyngeal cancer, especially in men. We're seeing very high rates. And in fact, you can see here from the numbers of these HPV associated cancers attributable having a clear etiological link associated happening in a part of the body that actually can be affected by HPV. So you can see here that for males, oropharyngeal cancer cases are more than 16,000 each year, with cervical just more than 12,000. So a significant number of people in the US each year are impacted with a cancer, a precancer, genital warts, RRP, if you add those all up together. When we take a look at the spread of HPV cancers by states in the United States, you can see this pocket here in the Mid-South and in the Southern US, where we see the highest rates overall of HPV-associated cancers. And overall, HPV cancers follow age patterns that are seen for other types of cancer, but with a slightly younger median and mean age for these particular types of cancer. But overall, still follows that trend that cancer is overall a disease of aging. I also want to take a moment to just talk about rurality as an important indicator. While here in Memphis, although I know not everyone may be from Memphis, here in Memphis, we're in a much more urban setting, but not too far from here, we enter into rural parts of our state, of Arkansas, of Mississippi, and rural and ethnic composition matters when it comes to thinking about how these different conditions affect our neighbors. We're all checking more than one box at any one time. And when it comes to HPV cancers, we see how that intersectionality of identity results in different disease outcomes, differential access to vaccines, and also differences in disease outcomes. So we have a lot of room for improvement. And you can see here in this map, which shows the different racial and ethnic groups combined with living in a rural area. So you can see where Shelby County is. Of course, it's not rural, but not too far from here, we'll see different areas where there are high proportion of rural, non-Hispanic Black populations, and also including a growing rural Asian Pacific Islander and rural white areas in this part of the country. So back to the rural piece in terms of burden, you can see here that overall HPV-associated cancers in rural areas are higher as compared to their non-rural counterparts, particularly for cervical and vulvar cancer, and also for oropharyngeal cancers. And these are cancers that in the oropharynx, at the base of the tongue and in the tonsils, that are not attributable to smoking and drinking. So for many years, oral cancer, head and neck cancers were largely a product of the synergistic effects of drinking and smoking. And that's really no longer the case. Sure, that accounts for a proportion of cases, but now more than 70% of cases of oropharyngeal cancer are linked back to HPV. Here's another look by race and ethnic group and sex, and we see that for HPV cancers, in spite of the growing number of oropharyngeal cancers among men, that overall women are experiencing more HPV cancers in comparison to their male counterparts. And then when we take a look here, we can take a closer examination of HPV cancers by site and also by race, ethnic group, and sex. And you'll see here that there are differences as we look across the different types of cancer. For example, and these are incident cases. And so, for example, Black women have a higher rate of cervical cancer as compared, Black and Hispanic women have a higher rate of cervical cancer in comparison to white women. And when we look at oropharyngeal cancer, it's actually white men who have the highest rate, followed by Black men, but white men overall have the higher rates. For all HPV cancers, here you'll see some slight differences, again, females more so than males, and then some differences in terms of the rates of women, Black women, Hispanic women in comparison to white women. So the story of HPV cancers is that they affect everyone, more women than men, growing number of oropharyngeal cancers in men, and all of this is something that we've continued to monitor for many years, but the good news is we have a safe, effective, and durable vaccine that can prevent 90% of every number that you see here in this table. So it's an exciting prospect that's been around for the last 15 years. I want to take a moment to talk just a little bit about cervical cancer. So cervical cancer was used as the primary endpoint for all of the investigational studies of the efficacy and then effectiveness of HPV vaccination because of the endpoints that were available. The cervical intraepithelial neoplasia, or CIN levels, as well as invasive cervical cancer. And for many years, we've known cervical cancer is a disease of inequities. And the World Health Organization and others have acknowledged this, and it's nearing crisis mode worldwide. So here in the United States, because of a largely effective screening program, however, we still lose more than 12,000 women each year are diagnosed, and about more than 4,000 are dying each year. Worldwide, on a global scale, it's closer to 550,000, and 300,000 of those women are dying in the absence of screening programs. And we know that most women who are developing and dying of cervical cancer fall into this rarely and never screened group. And so women across the world are actually failed in limited focus on prevention for cervical cancer. And these are women who are developing and dying of disease at early ages at which they are having families or that they are interested in wanting to have families. And so we have tools to eliminate cervical cancer, actually eliminate it, but it's the question of whether or not we have the will. So cervical cancer screening to reduce incidence and mortality in the post-vaccine era really remains very relevant. And so for pediatricians, you're not really going to see precancers of the cervix and cervical cancer, but you are the primary messengers for how to ensure protection against the vast majority of cervical cancer cases for kids as adults. And so the World Health Organization has put forth a very bold goal. In 2020, actually November 2020, they launched a global strategy to accelerate the elimination of cervical cancer. And this idea was first introduced in 2018. We already have the necessary tools, but how can we do it? Australia, where we've seen tremendous uptake of HPV vaccination, is on track to eliminate cervical cancer by 2028. That is only a few years away to eliminate cervical cancer because of high rates of HPV vaccination uptake consistently over several years. And Canada has recently set a goal of cervical cancer elimination by the year 2040. Also not that far away. And so what about us in the US? Well, the World Health Organization has put forth this bold set of specific targets for elimination of cervical cancer by 2030 as a worldwide goal. As I mentioned, Australia is on track by 2028. Canada is not far behind, and other countries are continuing to make progress. And so here are the 3 specific targets of the World Health Organization that they're interested in meeting in order to change what this picture looks like worldwide. And again, that's 550 to 600,000 women worldwide who are diagnosed with cervical cancer, a cancer for which we have excellent screening. We know a lot about how to treat it, and we know how to prevent it when we look further upstream. So just a few more slides about cervical cancer to just bring home this point about really the potential and promise of HPV vaccination. So here's what cervical cancer rates look like in the United States. You can see a clear pattern of the highest incidence of cervical cancer in the South in the United States. There are a number of other factors that you can lay here that influence the poverty levels factor in here, as well as access to care. Currently, there are 12 states in the US that have not expanded Medicaid. And what we've seen is in states where Medicaid has been expanded, that there's greater utilization of cancer screening and other prevention. So we know that there's some correlation between that type of access. We're fortunate to have the National Breast and Cervical Cancer Early Detection Program here in Tennessee as well, that offers women those access points, but perhaps not to the same level of it in other states that have since expanded. So this is just something that started to come out over time. Here also are what cervical cancer rates look like by race and ethnicity. And you'll see that Black women and Hispanic women have higher rates, as I mentioned previously. And then here, there's an earlier mean and median age at diagnosis. And so women who are mothers, women who want to be mothers or may want to be someday, these are the women who are affected by cervical cancer. So these are our mothers, our daughters, our sisters, our cousins, our aunts, our grandmothers. This is a range of different roles that these women are playing in our life. And you can see here that there's this shift. So it makes the impetus for HPV vaccination all that greater to be able to think about how we can completely change that map and change this picture of incidence of cervical cancer. And I think that's something that just expresses the power and promise of the HPV vaccination. And here's just a quick look at the Healthy People 2030 goal, which actually has been reduced. So we've seen a 75% reduction in cervical cancer deaths in the United States since the introduction of the Pap test in the mid-1950s. Not all women have benefited equally. As we could see, Black and Hispanic women still have higher rates in comparison to white women, and our rates are too high given the screening programs that we do have. But again, good news, HPV vaccination is available, but yet cervical cancer screening continues to remain in the conversation as we see only a proportion of the population vaccinated against HPV. So speaking of HPV vaccination, really what I'm here to drive home today to you is the power and promise of HPV vaccination to prevent cancer-causing infections and precancers, and also to prevent HPV cancers down the road. So we know, based on data that are available through sentinel surveillance and other surveillance studies, that HPV infections and cervical precancers, abnormal cells on the cervix that can lead to cancer, have dropped significantly since the vaccine has been in use. HPV types that cause most HPV cancers and genital warts have dropped 86% among teen girls. Among vaccinated women, the percentage of cervical cancers caused cervical precancers caused by HPV types most often linked to cervical cancer have dropped 40%. And this is in the United States with only modest uptake, as I'll share with you shortly. So that means each year, again, back to those numbers, that is 36,000 cases of cancer almost entirely preventable, 200,000 precancers almost entirely preventable. And we know that with type 6 and 11 linked to genital warts, also entirely preventable through this vaccine. So the recommendations that I'm sure all of you are very familiar with really focus on 11 or 12-year-olds, and then vaccination as early as age 9. So routine vaccination at 11 or 12 has been recommended by the CDC's Advisory Committee on Immunization Practices since 2006 for females and 2011 for males. That's 15 years for females and 10 years for males. So this is a vaccine that's been around for a very long time. And there have been recent updates. The most recent update is the 2019 update for routine recommendations through age 26. And then adults age 27 to 45 who may not have been vaccinated when they were younger can engage in shared clinical decision-making with a healthcare provider, because some people who haven't been vaccinated may benefit. Speaking of that, the American Cancer Society actually recommends against vaccination in the 27 to 45-year-old age group for a number of reasons, including the high likelihood of exposure prior to those ages, and really just thinking about how well it's going to prevent disease, given what we know about the robustness of the immunogenic response in younger children. The American Academy of Pediatrics and the American Cancer Society both have moved to the 9 to 10-year-old age group, and I'm going to talk a little bit more about the rationale for that move here shortly. The US has set lofty goals for HPV vaccination, Healthy People 2030, which provides us with the national's public health related goals, includes a goal for HPV vaccination. They used the 2018 NIS Teen or National Immunization Survey of Teens data as the benchmark, and we'll use that as the follow-up. And so you can see in 2018, it was 48%, and the goal is 80% by 2030. The Vaccine National Strategic Plan includes an interim benchmark of 80%, and then also wants to take that one step further to 2030 and get that to 85%. I know in our St. Jude program, these seem like lofty goals, but we have nowhere to go but up in terms of improving HPV vaccination uptake. And so these serve as important guides. The National Center for Quality Assurance Immunizations for Adolescents, or the NCQA, also has a benchmark. They want to see HPV vaccination series completion by the 13th birthday. Something I didn't mention, because I know all of you are very familiar with the guidelines. Of course, it's 2 doses before the 15th birthday and 3 doses thereafter, and also 3 doses for those who are immunosuppressed. So you can see here for series completion by the 13th birthday, that would be a 2-dose series. And you can see the low proportion of uptake across commercial HMOs, commercial PPOs, and Medicaid HMOs. Those numbers are not where we would like to see them. And this is the proportion of those who've met the by the 13th birthday for those different types of insurances. So there's certainly a lot of room for improvement here. And the other main data source I mentioned earlier, the NIS Teen data, which serve as the main guide. Many of you also very familiar with these data. I want to take a moment to show how here in Tennessee, our numbers actually went down from 2018 to 19 in terms of more than 1 dose of HPV and HPV up to date. Just a little bit, and still within the margin of the 95% confidence interval shown in parentheses. But you can see here that in terms of where we fall in comparison to the rest of the United States or the US overall, we're about 10 points below for both. And so we certainly have some room to make improvements here in Tennessee and also in surrounding states. Mississippi is the lowest, has the lowest uptake in the United States for HPV vaccination, which is a bit ironic given their tremendous success leading the nation in vaccinations by kindergarten. So there's certainly some fall off there between leading up to kindergarten and those required vaccines to what we see with adolescent vaccines. And then for Arkansas, we can see that they're just a little bit above where we are, but still fall below the national average. So certainly there's a good bit of improvement. And I've included states here that kind of fall into that mid-south and southeastern area, states that have seen some improvement from 2018 to 2019. And Louisiana is one I always like to point out, because Louisiana and recently Illinois just moved above, but Louisiana has really shown some great improvement in their rates. Here's another look, and you can see here that for HPV vaccination, more than one dose, and HPV up to date, that we've had a steady increase. We've seen improvements over time. It's just been slow, and the gains have been much less for tetanus or Tdap and meningitis or meningococcal conjugate vaccines, also recommended for the 11 to 12-year-old age group, as you well know. So you can see here that for Tdap, we're right up around 90%. For one dose or more of meningococcal conjugate, we're also approaching 90%. For 2 doses, still a little bit lower. And Tennessee has had a Tdap or tetanus requirement since 2010. And so within Tennessee, we've also seen steady improvement. These data here are for the United States, but also in Tennessee, we've seen steady improvement. And that Tdap requirement is, of course, for incoming 7th graders. But in Tennessee, we also are one of the few states in the US that do not have the meningitis vaccination requirement for that age group. So there are some other states, mostly in the South, that don't yet have that requirement. So perhaps that's an opportunity to think about how to improve uptake by making a connection to make it compulsory, as with tetanus. In terms of rural communities, I always like to mention rural communities when it comes to HPV cancers and HPV vaccinations, since there are such disparities there. You'll see here that consistently rural coverage is lower. It's been that way, and it's been slightly increasing at the same rate as urban areas, but still tends to fall 10 to 15%. Here it's about 12 percentage points lower than in urban settings. So I like to share this map to really lay it out. So I'm bringing in the HPV vaccination uptake map from 2019, NIS teen data, 13 to 17-year-olds on the left, and on the right, these are HPV cancers. And this area that's circled in green, of course, includes Tennessee, but also includes the areas where St. Jude has affiliate programs in 8 affiliate locations across this Mid-South and Southeastern United States. And you'll see here that what we see is in these areas where there is the lowest uptake of HPV vaccination, there are the highest rates of HPV cancers. So HPV vaccination, we know it's safe, it works, it provides long-lasting protection, yet uptake is less than optimal. And low HPV vaccination uptake occurs in these areas where we see the highest disease burden. So part of the impetus for this program at St. Jude is absolutely related to where in the US we're located and how we can potentially drive change in this space. So a few things about age at HPV vaccination. So age matters. There are many benefits to moving the recommendation to age 9 to 10. So that would sort of be going on the younger side of the ACIP recommendation into 9 and 10, separating HPV vaccination from the 11 to 12-year-old recommendation for Tdap and meningococcal conjugate. So this has been shown to have many benefits. I've included several sources down here that tout the benefits of this earlier move. And one of the most important things is we hear from healthcare providers. My time in South Carolina, I heard this a lot as well, that parents express concerns about sexual disinhibition, meaning that if we give this vaccine, it's going to increase the likelihood of a child becoming more sexually active, or my child doesn't need this vaccine because they're not going to engage in usual, normal, exploratory behaviors that are nationally seen for kids, very normal, usual behaviors. And so how can we address that? Well, by moving it to 9 to 10, you totally, or nearly totally, I shouldn't say completely, nearly totally remove the conversation about sexual activity with 9 to 10-year-olds. So the 9 to 10-year-old age group offers us a real opportunity to think about driving up rates and ensuring completion of the series by the 13th birthday, because they can complete this at age 9 to 10. So this has been shown to work in studies that have been done, and also is shown to be very acceptable, not only to systems and providers, but also to parents. Parents have also been receptive to this idea. And of course, HPV vaccination is a preventive, not a therapeutic vaccine. And so it's going to not only have the most robust immunogenic response at those earlier ages, but also prior to age at, again, initiation of usual exploratory behaviors that coincide with the age group and with usual human development. So here are some more data to really show you how important it is that we're vaccinating kids early. So this study was done in Scotland, and you'll see that if kids were vaccinated by ages 12 to 13, that HPV vaccination was 86% effective against CIN grade 3 or worse. And so that's important because these are the precancers that are diagnosed, part of those 200,000 in the US each year, and more, of course, worldwide. But this shows 86% effectiveness if by ages 12 to 13. But when we look at vaccination by 17 or later, perhaps you've heard this from parents. I'll just wait till my child goes to college. I'll wait until my child is older. Of course, there's the 2 doses versus 3 doses here. There's also an issue with effectiveness. You can see here that for women vaccinated at age 17 or later, that HPV vaccination was only 51% effective for CIN grade 3 or worse. So there certainly is a correlation between that earlier age group and having that long-lasting protection that's so important. And again, cervical cancer and precancer endpoints are used because they're easier to measure and ascertain, but we're seeing growing focus on other types of HPV cancers to identify similar surveillance studies. Recently, in the New England Journal of Medicine, just last fall, there was another study out of Sweden that showed us the best data on HPV vaccination and preventing cancers have really come through monitoring these precancerous lesions. So CIN 1, 2, 3, et cetera, of the cervix. And so this study from the New England Journal shows us that if vaccination happens by age 17, that there's 88% protection against invasive cervical cancer. So not only does HPV vaccination prevent CIN3 or worse, it's also shown to prevent cancers. And so we are starting to see the data roll in. And of course, we were already learning this from what was happening in real time in Australia, but we see a clear reduction in disease burden with vaccination, and particularly with vaccination at earlier ages. So this chart shows cumulative incidence of invasive cervical cancer based on HPV vaccination status, and age at follow-up is truncated to the graph because no cases of cervical cancer were observed in any girls younger than 18 in this surveillance study. But you can see a clear link between earlier age at vaccination for those who were vaccinated at less than 17 years of age compared to those who were vaccinated in the 17 to 30-year age group, and also in comparison to those who were unvaccinated. So the take-home message here is very clear that HPV vaccinations not only are safe, we've had more than 270 million doses worldwide. Safety data are very strong. It works. We can see here that it actually prevents precancers and cancers, and it provides long-lasting protection, especially when we look at those earlier age groups for vaccination. So HPV vaccination does offer us that powerful tool and promise for preventing these precancers and cancers that I think are so important. Gosh, we care a lot and do a lot for kids, especially all of you who are providing direct care to them. And here's something that's safe, effective, and lasts that can help protect them from getting a cancer when they're older. Right now, during the pandemic, there have been major changes to vaccination. And this is, of course, a result of maybe all of you have had adjustments to your practice and how you're treating and caring for patients. We also know that parents and caregivers who are going to bring kids in have had some reservation, want to make sure that it's safe, and for preventive things, maybe that's not as urgent. Well, we've certainly seen the effects of that. So the current COVID-19 pandemic gap is very much larger for some vaccinations as compared to others. So these are data from Dr. Melinda Wharton at the CDC, and these are public data that she's presented several times and are available publicly through the CDC immunization program and website. But you can see here for routinely recommended pediatric vaccines that DTaP containing vaccinations down, PCV13 is down, rotavirus vaccine are down. So those are down, but not quite as much as what we're seeing for adolescents, which have consistently stayed at about this 20 percentile reduction. Now, remember, in the United States, we're only at about 54% uptake overall. And so we've already seen a 20% fall off, and there's little room for us to have that kind of fall off and really experience the benefits in the short and long term for prevention. Measles containing viruses being down 21%. As you know, measles are very contagious, and being down 21%, if that happened all in one community, that community would certainly be at high risk of a measles outbreak, especially in younger infants who haven't yet had their first measles vaccination. So that's also very much concerning. And then we see that pediatric vaccines have recovered at near pre-pandemic levels, as shown here, but also we've seen adolescent vaccines persistently remain at these lower levels. So here's another way to look at what's happening across this adolescent landscape. So HPV vaccinations currently down more than 21%, and that represents a miss of more than 1 million doses. And these data are from earlier this year, and we continue to monitor these data. St. Jude is part of a national Get Back on Track group that meets monthly to really focus on data and try to identify ways for us to ring the bell and let providers, let healthcare providers, and also let the community and parents and caregivers know, let's go ahead and get back on track. This is going to be incredibly important. Here are some data from tennis. So these are tennis data. Tennis includes about 60 to 70% of kids in the state of Tennessee. So it has relatively high participation and coverage. And the tennis program provided us with these data. We've been carefully monitoring the total number of HPV doses that have been administered from 2019, 2020, and now 2021. So these data are current through January. And you can see that we're still down about 20% for that 9 to 18-year-old age group, from a high of being down 64% in April, 35% in May, some recovery there in June and September, but otherwise continuing to lack the recovery of getting back in for vaccinations. So there are some major challenges when it comes to this, and these huge deficits that started in April, May 2020 in particular continue to drive these lower numbers. Vaccines for children, or VFC ordering, has been rebounding, but still has stayed down nationally. And the persistent declines with minimal evidence of return and stabilization are important because we know Pfizer has already applied to the FDA for emergency use authorization for their COVID-19 mRNA vaccine for 12 to 15-year-olds. So it's coming for this age group. And we have a lot of kids who've missed out on doses of vaccine over the last 13 months. And so these routinely recommended vaccines may continue to be pushed off because preliminary data show the 14 days before and after. So there's a period of 49 days for the Pfizer vaccine, or 7 weeks, where a child could not get any other vaccines except that vaccine. And so that creates a real urgency for starting back to school right now, starting to reach out to parents and caregivers about getting their child in for routinely recommended vaccines today, so that if they choose to have their child vaccinated with the COVID-19 vaccine, that they're able to do that. So the sheer magnitude of adolescents who need to catch up because they missed out on vaccinations is huge. So those huge numbers. And we've seen, some changes to capacity. Perhaps in your settings, you're maybe operating back to usual or maybe a little bit less than usual. Nationally, we've seen kind of in the middle. Some people are all the way back. Some people are still at reduced capacity. But for places where there are huge numbers of kids who need to get back in, it's really time to start doing that right now. We also know that adolescents who've missed out present particular concern, because among publicly insured adolescents who have likely experienced the pandemic very differently from privately insured counterparts, for example, they're going to have short and long-term effects that are very different. And we need to get them vaccinated because they are maybe going to age out of the VFC program, maybe have less access even with the VFC coverage for their vaccinations. We used to see a reverse disparity in HPV vaccination. I really don't care for that term. It's just a way to say that oftentimes we would see publicly insured children actually have higher rates of HPV vaccination uptake compared to privately insured counterparts. The public-private gap has just consistently widened. Right now, with well child visits, we see about a 30% decline for publicly insured children and about 15% for privately insured. So the gap is twice as much for kids who are insured through public programs. And timing, as I mentioned, COVID vaccination is coming for this age group. And so 49-day kind of a blackout period, so to speak, where no other vaccines can be administered really creates some impetus to get back on track right now with vaccines and reaching out to parents and caregivers to doing that. So the CDC has recently published Help Kids Safe Return to School guidelines to get caught up on recommended vaccines. And here are just some of the strategies for what state government agencies can do, what healthcare systems and healthcare providers can do. Take a look at your data. Who hasn't been in? Who's due? Who's aging in? Who missed out in the last year? Doing some proactive outreach or messaging to try to reach those parents and caregivers, encourage them to call, having drive-through vaccination events to help kids catch up, have their parents coming through parking lot, drive-through visits. There's a number of different strategies that have been used to try to help get back on track. And at St. Jude, we've been leading an NCI designated cancer center statement process where we're looking to issue a statement about the urgent need to get back on track, especially with HPV vaccination, which we know has fallen off significantly. It's hard to share these 2018 and 2019 data because we know the 2020 data will look nothing like the 2018 and 2019 data and will create a real gap in our protection of kids of those ages. So the NCI cancer centers are working on a statement to put forth in support of the CDC and other organizations, including the American Cancer Society and others. I'll have my slides shared with you guys so you can take advantage of some of these resources. So I have a number of different resources for getting back on track with HPV vaccination that may be of interest to you. And the ones that are included here from the HPV Vaccination Roundtable, the National HPV Vaccination Roundtable, include actually ready to go messages that can be pushed out to parents and caregivers who are parents and caregivers of children who are due for vaccines. So some really ready to roll resources that could be very useful as you're working to get back on track. So let me take a few minutes here and just talk a little bit about evidence-based interventions to increase HPV vaccination. So we have been studying interventions to increase uptake for 15 years, just as long as the vaccine has been available. And some of that work started prior to the FDA licensure and ACIP routine recommendation for HPV vaccination. And we know that there are interventions that work on the supply side, So that's the healthcare system-based side, and also the demand side. We want to make sure that parents have the information, parents and caregivers have the information that they need to make a decision that's in the best interest of protecting their child from these HPV cancers and other diseases as they get older. And we want to make sure that within a healthcare system that there are strategies to increase that demand, making sure that there's a strong presumptive healthcare provider recommendation, and that from check-in to check-out in a healthcare setting, that everybody's on board with the fact that we support vaccinations. The World Health Organization has identified vaccination hesitancy as one of the top 10 threats to global health. And we know that those sentiments have only been growing and perhaps maybe fueled by what we've seen with the pandemic. And so as a result, it's important now to make sure that within the healthcare setting that you have systems set up in support of vaccination and are giving a strong recommendation. And also in terms of messaging, we're trying to work on that demand side, the community demand side, to make sure that we're able to support the decision-making of parents and caregivers. So a lot of times when we talk about a strong recommendation, sometimes it's a little bit unclear what that exactly entails. And so Dr. Noel Brewer, Dr. Melissa Gilkey, and others at UNC Chapel Hill have been studying what constitutes a strong presumptive recommendation. Well, here are the components to that. So a presumptive recommendation has been shown to be 9 to 10 times more effective than another type of recommendation to a parent or caregiver and really result in HPV vaccination uptake. So the first step is to make sure you acknowledge the child's age. So whether you're doing this at the 9 to 10 or 11 to 12-year-old visit, whatever is your practice, making sure to note the child's age, announce the children this age are due for this vaccine that prevents several diseases, and say you're going to vaccinate today. So it's your child, this is routinely recommended, and today we're going to go ahead and give you this vaccine. So it looks like this. It's now that Abigail is 11, she's due for 3 vaccines to protect against meningitis, HPV cancers, and pertussis. We'll give them at the end of the visit. And that's the end of the recommendation. So this exact recommendation, this formula has been shown again to be 9 to 10 times more effective in yielding uptake among parents and caregivers. And we know that there's a lot of different ways that healthcare providers know their parents and caregivers best, know their patients best. And so in some cases, there may be another strategy that's going to work better for those particular parents and caregivers. But overall, this presumptive recommendation has really been shown to be highly effective. As I mentioned about vaccination hesitancy, vaccine acceptance, so alternatively, vaccine acceptance occurs on a continuum of these different levels of vaccine confidence and acceptance. So refusing all vaccines is on one end and accepting all vaccines on time or as recommended is on the other. And somewhere in the middle is where hesitancy or reluctance or refusal to vaccinate emerges, despite having availability and access to vaccines. So in simple terms, vaccine hesitancy leads to refusing some vaccines, delaying some vaccines, and accepting some vaccines. This happens a lot with 3 vaccines that we've seen in adults, and it happens with 2 vaccines that we've seen with adolescent populations, seasonal influenza and HPV vaccination. So these are 2 vaccines where you may be able to take a look at your data and know that parents and caregivers say yes to every vaccine you recommend, except flu. And maybe they delay. Maybe they don't outrightly refuse HPV, but they delay and say, I want to wait till next year. I want to wait till my child is older. And so for many years, this has really been being tracked and refers to this. And we know hesitancy varies across time, place, and vaccine type. And it's influenced by factors including complacency, convenience, and competence. And so all of those factors really have to come into play. And so vaccine confidence is the trust that parents, caregivers, patients, or healthcare providers have in the recommendations for routinely recommended vaccines in their healthcare provider who administers the vaccine, and the processes that lead to vaccine licensure and the recommended vaccination schedule. We also know trusted messengers are very important. The most trustworthy source of vaccination information for parents and caregivers, even for those who believe vaccines are unsafe and those who request exemptions for some vaccines, really comes back to healthcare providers. So we know there are different strategies to be able to help build confidence, and you play a very important role in that process. So as healthcare providers, you can make a strong presumptive recommendation to every parent, caregiver, or patient when appropriate for HPV vaccination today. You can use that formula to acknowledge the child's age, so it's personal, the routine recommendation of the vaccinations, and then lastly that you're going to do it same day or today. So that's a way to make a change. Also normalizing HPV vaccination and sharing facts about HPV vaccination, which unfortunately for another talk, another time, has been mired in disinformation and misinformation for several years. That's really resulted in hesitancy for HPV vaccination. So here are a few resources for you. Again, I'll share the slides so that you can access these. I really love the American Academy of Pediatrics HPV Vaccination Champion Toolkit. While it is targeted at pediatricians, I think it's relevant to any healthcare provider. I think the messages and the idea of having a vaccine champion, utilizing quality improvement approaches, and really building a supportive vaccination environment within the healthcare setting makes a difference. There's also resources from HPV IQ, which is Dr. Brewer and Dr. Gilkey, ACS, and then the National HPV Vaccination Roundtable. So HPV vaccination, it's safe, it works, provides long-lasting protection. There's lots of evidence in support of all of those factors, safety, effectiveness, and durability. And we know that uptake is really less than ideal, especially in areas where we see high burden of disease. And so now I want to just take the last couple of minutes, and then there'll be time for questions, to talk a little bit about the St. Jude HPV Cancer Prevention Program. So since the founding of St. Jude in 1962, St. Jude clinicians and researchers have asked and answered really big what-if questions that have changed and transformed the landscape of childhood catastrophic diseases. And today, the hospital is guided by this strategic plan and also these opportunities to still have really big ideas. And so Dr. Downing, who's the president and chief executive officer at St. Jude, initiated this formal process for these big what-if questions to be asked and answered through this Blue Sky projects to help accelerate progress. So one such idea came following Dr. Downing's participation in national meetings focused on transforming cancer research. And it was through these meetings that Dr. Downing learned of slow uptake of HPV vaccination to prevent some types of cancer. And so Dr. Downing shared his observation with Dr. Charlie Roberts, who's the director of the St. Jude Comprehensive Cancer Center, and other clinicians and team members at St. Jude. And then they focused in on what if we at St. Jude, a known, trusted, recognized brand among parents, could accelerate efforts to prevent adult cancers by vaccinating children. So we don't yet know how to prevent pediatric cancers, but here's an opportunity to help kids be protected from cancers they may develop as adults. And so as the only NCI designated cancer center focused solely on children, St. Jude has a really important role in this space to try to work with existing partners and initiate new efforts to really ensure that uptake is accelerated. So our program launched on March 4th, 2021, which is International HPV Awareness Day. And St. Jude has made a significant investment in supporting the program. That type of possibility that becomes reality is what certainly drew me to this position at St. Jude. And we're going to be focusing on working with partners, healthcare providers, and others, just like all of you represented here today, to really understand how we can strengthen existing efforts and bring those to scale, and also implement new efforts where there are opportunities. And you can certainly reach out to Carol or me if you would like to see the launch email. We'd be happy to send that your way. And so one of our greatest challenges is going to be prioritizing where we have an impact in the space. We've seen slow uptake. We know there are still large proportions of young people in need of being vaccinated. And so one of the ways that we are going to organize our efforts are around these spaces, really looking at community interventions, so that community demand side, healthcare providers and systems, so that supply side, and how can we cultivate community clinical linkages. We're also going to be doing work in the policy and advocacy space. St. Jude really has been taking a look at what's happening in the policy space, and I'll share with you an upcoming virtual seminar that we're going to be holding that's going to take a deeper dive into policy across 4 states. And we know there are already groups doing really good work. And so how can we be good partners? How can we serve as a resource to those partners and be supportive of their efforts? We've been doing a lot of different awareness activities. Dr. Melissa Hudson and Dr. Kari Bjornard have authored a blog. Some of us on the HPV team have also written blogs just to help try to highlight the opportunities for increasing HPV vaccination. And this one in particular is focused on getting back on track with HPV vaccination. And this was written in January, but still very relevant given what we've seen with the persistently low rates. So we're hosting this virtual seminar so the goal of this seminar is to share the results of a policy analysis of HPV vaccination in 4 states: Arkansas, Mississippi, Missouri, and Tennessee. So these states have lower uptake overall relative to the US. And so we contracted with an external vendor to take a closer look to help us identify opportunities or challenges to future legislation or actions that are included in these 4 states, but are likely to be relevant more broadly in other states. So we have a great group of discussants who are going to join us, including Dr. Lisa Piercy, the commissioner of the Tennessee Department of Health here. So we're really excited to have this group and really talk about policy change. We also have been supporting Dr. Sokwon Jin at the University of Memphis, who is currently conducting an online survey with parents. So these are parents of 11 to 17-year-olds in the Mid-South, and specifically here in the Memphis-Shelby County area. So this is a survey to add to some of the previous mixed methods research that he's been doing. And I thought this may be an opportunity that you guys may be interested in sharing, or maybe even participating in, should you have children in this age range. So overall, our program is really getting started by connecting with partners and really thinking about how we can amplify work in the public policy and advocacy space. Also here, obviously, a connection on the clinical side, working with community groups, and then thinking about how we do that in partnered ways with the organizations who are participating and have convened this event as well. So we know that your recommendation matters, and your entire clinical environment matters to uptake, and age at vaccination matters, for sure by the 13th birthday, but also consider implementing the American Academy of Pediatrics and American Cancer Society recommendation to move to that 9 to 10-year-old age group, and work to build confidence in parents and caregivers. The more we can normalize HPV vaccination as being safe, effective, and offering long-lasting protections against these HPV cancers, the more that we can hopefully kind of change the way in which people are viewing HPV vaccination. We hope that you'll reach out to engage us if you're interested in working with us. We've organized our team to provide support kind of geographically. So here in Memphis, Shelby County, Carol Miner and Katie Midgley are working with partners here. And then we also have some designated state representatives. So in Tennessee, Carol's been handling Tennessee, Julia's been handling Missouri, Katie for Julia Neely's been doing Missouri, Katie's been doing Arkansas, and Carol's also been doing Mississippi. And Andrea and I have been handling most of the regional and national efforts as well. So our program is really excited to be here. We're really excited to find ways that we can work with you and support your work. And I certainly welcome any questions or additional comments that you may have. Here's my contact information if you're interested in reaching out. Thank you so much.
Dr. Brandt, thank you so much for sharing with us tonight. You've presented a lot of eye-opening stuff, and I really appreciate that. And I feel your pain. I feel everybody's pain about the flu shot and the HPV shot being turned down so much. It's painful. So I look forward to having this become just one of the expected vaccines, the routine vaccines. So anyway, I really appreciate your time. I appreciate everybody else tuning in. Are there any other questions that we have before we break?
I'll ask one if it's okay. Dr. Brandt, obviously speaking in front of groups like this helps spread the message. What else are y'all doing to try to spread the message, and how else might we be able to help you?
Sure. So we welcome any opportunities like this to talk to organizations and also within your healthcare setting. So we can tailor presentations to provide information that is in support of the work you're doing. So that's sort of a low-hanging fruit. For the higher order items, right now our program is engaged in a strategic planning process where we're going to be prioritizing different strategies. One of those strategies, particularly relevant to all of you, is our focus on clinicians in healthcare settings and healthcare systems and working with healthcare providers. So we're looking at a combination program that is going to be focused on provider recommendation, so a strong presumptive recommendation, and offering that training that I mentioned that has been shown to be so successful. In some states where they have implemented the training program, they've seen huge gains in a very short period of time as healthcare providers are interested in that. And secondly, quality improvement approaches. How can we work with you to take a look at how you might use your data? And so the American Cancer Society, also HPV IQ, and other organizations have developed some pretty simple tools for, just do these 3 things. Don't feel like you have to do a whole quality improvement project, but let's just do these 3 things. Let's take a look at your data to see where you are. Let's do a couple of time points. Now let's think about what's happening that's maybe causing, so root causes. So first, where are the data, root causes? And then here are some strategies that you can employ to try to help you reduce missed opportunities and take advantage of those encounters. So those are some examples in the clinical space that we're working towards. In the public space, on the community side of things, we've been talking about doing a huge messaging campaign. St. Jude has such brand recognition, not only here, but also nationally and globally. So how might we really get out there with some messaging that's going to be thought-provoking and really result to action? But if we're going to do that action, we want to make sure that healthcare providers and healthcare systems are ready for that experience. On the policy and advocacy side, the virtual seminar is going to be a way for us to share information about the current policy landscape. But then also we're going to be supporting legislative education efforts because we know our legislators are tasked with many things, and there's many issues that come before them, much like you and your role as being a provider and all of the things that you're thinking about taking on. So we want to provide legislators with education. Right now with COVID-19, that the advent of vaccines has resulted in just a tremendous surge of legislation to expand exemptions and to limit public health authority of health departments. And so that creates a concern for vaccinations, because obviously we would prefer that the only exemptions be medical exemptions so that we're able to limit philosophical belief, religious or other exemptions. And then for public health authority, in the case of an outbreak, it's of course, it's critical for the health department. I mean, if there's a measles outbreak and it's declared as an outbreak, current legislation could restrict the health department's ability to go into that community and take over to try to mitigate the spread and of course isolate it. So those are some concerns right now in the policy space that we're paying attention to. So there's just a few examples of things we're looking at with our strategic planning process.
I have a question. My name is Tim Gillespie. I am in practice. My practice is largely urban in Whitehaven, a large TennCare population, as well as in North Mississippi, which is largely commercially insured. In each case, in each location, I get the same response. It doesn't matter, you know, when you bring it up at 11, they're either for it, as you said, or not just against it, but with vitriol. It's almost a visceral response that they have to the HPV vaccine specifically. They want everything but. And I don't know how to combat that, but I waited for you to get to the end of your talk and in anticipation of you saying St. Jude is going to do something about that in terms of messaging to the community. And I think that is a huge, that would be a huge deal for me personally. And I think it would be a great thing for the community. I just think if St. Jude came out and said, look, this is cancer, where's a way to prevent it? Instead of getting them the CDC handouts, you know, which we do, say, read this, come back in a year, think about it. And, you know, the trust for CDC right now is not great either.
Tim, that's a great point. Thank you so much for bringing that up. And as I mentioned, one of the areas we're really looking at is that messaging opportunity, because St. Jude is a known, trusted, and recognized brand by parents. And so how might we be able to leverage that trust that's been established over many years with parents? You know, St. Jude has the best interest of their kids and of all kids in mind as they're working hard to cure diseases and identify less toxic treatments. And here in the prevention space, we care a lot about kids. We can't prevent those cancers or other diseases right now. So here's something that can protect kids today. It's a powerful approach, and it's definitely on our radar. We are starting the process of working on some educational materials that we certainly, I'll have Carol circle back with all of you through these various societies and organizations to share, that we will be making available that you can use, that will include St. Jude and the strong endorsement by St. Jude for this vaccination as cancer prevention.
Thank you very much.
Thank you. Well, I just want to emphasize again that I really appreciate your invitation to present to you today. Welcome opportunities to present in other settings as there may be opportunities, and also to think about if you have any needs, anything we can help you with, especially right now during the pandemic, point you in the right direction for things, all of that stuff. And we'll make sure that the slides get shared. Carol will give those to Cara to share with you, so you'll have all those links. I put some of them in the chat, but we'll make sure you get those too. So I really appreciate your time and this opportunity. Thank you.
Great. Thanks, everybody. And y'all stay tuned in the coming weeks and months. And we say this every time, but hopefully we're actually going to come together in real live person and have some dinner as well as great conversation like we've had tonight. So thank you very much, everybody, for participating. And I hope y'all have a good night.
Thanks again. Y'all take care.